And I think I may have a question to discuss with you. In the planning part, we can see from the Delphi chart you shared today, I can see both UC and Crohn's disease. You have the early endoscopy examination as early as week 10. But usually in our clinic, we will somehow delayed or choose the timing of endoscopy based on the characteristics of the medicine we are using. For example, if we use upadacitinib, which is fast-acting medicine, we might re-examine the endoscopy earlier. But for medication that with a low onset of the efficacy, we might delay it even to maybe 3 months later or even to 6 months later, especially with patients without symptoms and with normalized calprotectin and normalized intestinal ultrasound. We usually will delay the first endoscopy after induction. So I may want to hear your opinion on this.
Yeah. I fully agree with your approach, and I think it's important to set the scene also on what I've shown. In Belgium, there is an obligation in patients with ulcerative colitis to do your endoscopy after 10 to 12 weeks to do a reassessment endoscopically to have reimbursement. So this is why we do it in ulcerative colitis that early. I agree that indeed there is you can adapt your approach to depending on the severity of the presentation initially, but also to the drug that you choose. And indeed, some drugs have the appearance that they work slower, and that you can postpone that treatment. The second thing is that for Crohn's disease, there is not an obligation in the to do that endoscopy so early on. What I showed in the graph was radiological assessment or endoscopy. So we almost never do early endoscopy in Crohn's disease. If we do an assessment, we do intestinal ultrasound at that moment. Like I showed you also in the study, that it's after 3 months that you see really that important change. And if you haven't seen that, there is a reason to adapt your treatment with intestinal ultrasound. We do mostly our endoscopy after 1 year of treatment in Crohn's disease. So we had that discussion whether we should do it, like you say, after 6 months in Crohn's disease or later on. Because we want to standardize our approach, we agreed that we would do it after 1 year of treatment, meaning that we do that, let's say, at the end of maintenance. So after 1 year of treatment, because then we are sure that this is aligned, first of all, with the STRIDE guidelines, and even for slower acting compounds or apparently slower acting compounds, that we were sure that we do the assessment at the right time and have the maximum results at this moment. And the last point I wanted to add, I think there is sometimes the idea that some drugs are working slow. I think sometimes it's said about vedolizumab, but if you look at the detailed data, for example, of the study that we did in Belgium, which is the LOVE-CD study, there we saw that improvement already has the maximum improvement is already seen after 26 weeks, and that the additional gain is not so big after that. So you could it's not working that slow probably, and indeed, as you said, 6 months is also probably a good moment. Important thing is that you standardize it and you do it in the same way.
Yeah.
Okay. Thank you. And if time permit, I have another question.
Yeah, you have time.
Could you share some experience in combining combo therapy of the advanced medicine?
Yeah, we have not that big experience, as of course that this there's not a reimbursement structure, but we have some patients where we can do it in special situations. I think in combination you have to be very selective in what you do, and I see I don't think there's a place for combination therapy in all patients at all at every moment. Most of the patients in real world will have a good control of the disease, about more than 50% with a good control of the disease if you start a treatment. That's what we see in real world. There are, of course, those patients where you see that there is insufficient control, and I think there's for me the most specific place for combination therapy. If you see that there is a response but insufficient, but there could be an additional gain, eventually in those patients you could start the combination therapy. And second place where I would do it is in very severe presentations, where you give that combination. For example, the combination of vedolizumab or ustekinumab with a JAK inhibitor, which is I think is a good combination. But there again, you should give it in a short period of time and assess after 3 months to see whether there is a control. If there's no control after 3 months, I think there's no place for further combination therapy, because it's also there's a big safety issue, of course, also on it. Yeah.